My name is Amy Freeman. I direct the Brooklyn Health and Housing Consortium, and we work very closely together with the Bronx Health and Housing Consortium. And together, as the Health and Housing Consortium, we've been organizing town halls since last March on topics related to the COVID-19 pandemic. And our goal in running town halls is to bring in experts and representatives of the agencies together to talk to frontline staff and others working sort of at the intersection of health and housing, and bringing information to folks on the ground working face-to-face with patients and clients, and providing this sort of forum for hearing the information and having a place to ask questions and share knowledge, and hopefully improve care for the people who we're serving. The topic of today's hall is vaccinations for individuals experiencing homelessness in New York City and beyond. We have an amazing panel of speakers with us today, who our moderator will introduce shortly. First, a couple of quick housekeeping items. Everyone, this is a Zoom webinar, so everybody is on mute with their video off. Please use the Q&A feature at the bottom of your screen to type in any questions for panelists. If you'd like to share resources or comments or introduce yourself, please use the chat box, and make sure you are sending your message to all panelists and attendees, because the default is to panelists only. We also have live transcripts available. There you should see a button at the very bottom, at the bottom right of your screen. If you're interested in being able to read the live transcript, please click there, or if you want to turn it off, click again. And then please do stick around. Towards the end of the session, we'll have an evaluation poll, and this really helps us get a sense of whether our events have been helpful and how to plan for the future. So our agenda for today, we'll first introduce our speakers, and then each panelist will give their presentation for around 7 to 10 minutes each. And then we'll use the rest of the time for a moderated Q&A discussion, and then we'll have our evaluation at the end. So to get started, I am really thrilled to introduce our moderator, Dr. Jordan Foster. Dr. Foster is an emergency department physician at New York Presbyterian, and he's also the ED Director of Government and Community Affairs at New York Presbyterian. So thank you so much for joining us today, Dr. Foster, and I'll let you take it from here.
Thank you. Thank you very much, and good morning to everyone. Thank you for participating in this event. It is my pleasure to introduce the 5 speakers for today. All have been committed to the projects that provide services to the homeless. We have first Dr. Fabienne Laraque. She is the Medical Director, New York City Department of Homeless Services. We will then have Dr. Jim O'Connell, President, Boston Healthcare for the Homeless and Assistant Professor of Medicine at Harvard Medical School. We have Dr. Lee Isaacsohn from the Brooklyn Queens Street Medicine, Primary Care Supervisor for Breaking Ground and part of the Janian Medical Care. We have Dr. Irene Swanenberg, attending physician at Bellevue Adult Primary Care Center and the Safety Net Clinic at New York City Health and Hospitals, Bellevue. And finally, we'll have Dr. Julian Watkins, Senior Clinical Advisor at New York City Department of Health and Mental Hygiene and leader at Culture of Health Leaders. So we can start with Dr. Fabienne Laraque.
Good morning, everyone. Can everyone hear me? Thank you very much. Thank you very much for this invitation from the Health and Housing Consortium. It is a pleasure to be with you today to talk about all the work that DHS has been doing since the beginning of the pandemic. I'm very excited to share where we are with vaccination for our clients. As you all know, and anyone who is in public health really knows that this is the opportunity of a lifetime to apply everything that we know to controlling this frightening illness. To that end, can I have the next slide? I'll start talking about what we've been doing. So vaccination at DHS is multiple front. We are offering both the Moderna and the Johnson & Johnson vaccine in several settings. We have a DHS point of dispensation at one site, and we are also offering mobile vaccination at all our congregate sites. We are also lastly collaborating with our site-based clinics. And I'll mention what we are trying to do with vaccine promotion and awareness and vaccine hesitancy. Next. So as everyone was in, by late November, December, we started planning for vaccination at DHS. Because of the complication of Pfizer and Moderna vaccine, we decided that with the health department that using the Moderna vaccine was a little bit easier, and that having a single point of dispensing to start with, we were planning to have more than one, but we started with a single point of dispensing at one of our shelter that had been emptied and moved into a density hotel, and that has space for this vaccination. So we started on January 18. We contracted with medical providers to provide the vaccinations, just the clinical portion, in our department with the Department of Social Services, basically organize the whole process. Scheduling, operation, we had volunteer on site. We provided access to vaccination 6 days a week, all day from appointments starting at 8 or 9 until 5, 6 in the afternoon. And we started with offering to 1 to 3 shelters a day. Each shelter would be given a block of time, and we had an online appointment system. We have an online appointment system. We contacted the shelter, give them the instruction. They scheduled client and staff. And we started obviously with who was eligible at the time. So we started with a congregate site. Not all of our shelters are congregate. The family with children, for example, have their private unit. So they are still not yet eligible unless they have chronic medical condition in New York State. So we started with the congregate shelter, and we started with high priority clients. So we scheduled first shelters for seniors. During the height of the pandemic, when we moved clients into hotel, we moved seniors into specific hotels. So we started with the senior hotel, then we moved to the shelter that were identified, but we're still in traditional shelter with dorm room. Then we moved with shelters that had a number of cases during the second wave in January. And then we started scheduling all the other shelters. And by the middle of February, we started trying to push to have vaccination on site, because at the pod, the shelter would have had to transport our client to the pod. And we did a really good job vaccinating a lot of folks at the pod, but we knew that on-site vaccination was really the key. So we started planning to use the Moderna vaccine at on-site at shelters. And as we were planning for that, Johnson & Johnson became approved. So it was sort of a no-brainer for us to really decide to use the Johnson & Johnson vaccine, given that the Moderna requires 2 doses. Just one more thing about the pod, we obviously are currently offering the second, going through 2nd doses. But because Moderna requires 2 doses, it requires freezing. We needed, for the mobile vaccination on site at shelter, we needed medical grade freezers, being able to transport those. Once the dose, the Moderna is defrost, we could not transport it back. They have 10 doses per vial. It's very hard to to really plan to finish a 10-dose vial if it's open, say, in the late afternoon. So with Johnson & Johnson, with the, it's not necessary to freeze, it's 1 dose. It's only 5 doses per vial. It really makes things a lot easier. And just for the backdrop on how we are able to provide Johnson & Johnson vaccination at literally every single one of our congregate shelters. So we've been offering COVID testing since May. We started with with congregate site, and by July, we were offering to really all our single adult site, our adult families, all our street sites, safe haven, stabilization bed, drop-in centers, and we have about a dozen or so family with children site where the family have their own unit, but they share a bathroom in the hall. So we started offering testing at about 200 sites per month, every 4 weeks since July. We contracted first with 2, and now we have 1 medical testing providers. They have a full team with administration, testers, nurses, EMTs, and a team lead. It's about 6-7 folks per team. By now, we started with maybe 8 teams. Now we have 11 teams a day. So they're essentially going to at least 11 shelters per day. With small sites, small drop-in centers, they are able to do 1 in the morning, 1 in the late afternoon, evening. So on any given week, we are present at 55 to 60 sites per week. And we go through all 200-something sites per month. So the testing has been going really, really well. We schedule all the site. We don't have that much staff, so we were lucky to be able to hire temporary, really smart, eager to work temporary staff. So we have a whole operation that schedules the testing. We work with the lab, we work with our providers. We really have a very well-run testing operation. And to me, was also a bit of a no-brainer. Let's just add vaccine to testing. We have the operation, we have the scheduling, the shelters are used to seeing our providers come. They come every month. We have the space. We needed a little bit more space. So essentially, that's what we did. On March 4th, we started, well, 2 weeks before that, we started working closely with the Department of Health. We had a lot of planning work. They had to vet our providers. Medical providers, the provider had to undergo training. We had to undergo training. We did a lot of planning, daily, night and day. By then we had 1 medical provider down from 2, and this medical provider had to step up really quickly from 6 to 11 teams to take over the entire operation. We had to estimate how much vaccine we needed per day or per week, which is really not easy. It's do we look in an 8-ball? Do we use tarot card, or what? So what we decided to do is to use the response rate to our testing efforts. So on average, on a given month, we have a response rate from about 24, 25 to 28, 30% on a good month to testing. A lot of our clients do not want to test. Unfortunately, we have flyers, pamphlet, posters, education session. We educate our staff. The staff educate the client. The site directors really go around every month. They go around the facility, knock at door, and advertise for the testing. But still, we are pretty much capped at 30% acceptance rate for the testing. So we use the average of about 25% response rate to testing to estimate that perhaps our vaccination response rate will be about the same. So we made that calculation for the to get the allocation from the Department of Health, and then we made site by site allocation based on their client caseload. So we basically multiply the client caseload by an average of 25% response rate. We also took into account if the shelter had been offered vaccination at the DHS pod, then we remove the client that already been vaccinated. So every month now, every week, we do this. After we've done the schedule, we do the allocation, which is side by side. Then we look at our allocation, we round it up and down to multiples of 5, since there's 5 doses in the Johnson & Johnson vial. And then if a site is able to schedule and had a lot of demand, then we increase the allocation. If they are less demand, then we'll give them the allocation anyway in the hope that people will just show up. We have fact sheets, flyers, posters. Again, the site directors, drum up business. We do session with the staff. I've done a lot of, several talk with the shelter directors to advertise for the vaccine. So we have a team that provide the vaccines on site. The shelter's role is to advertise and recruit clients, sign them up. We started with a spreadsheet for sign up. We now have an online scheduling that the shelter directors work with the clients. Johnson & Johnson is prioritized for clients, but at the end of the day, if there are staff that are interested in Johnson & Johnson, they are also eligible to get vaccinated. My team, we schedule, we organize, we monitor, we analyze data, we develop, we have an app called Canton where we've entered all the testing data, and we are now entering all the vaccine data, and we prepare a report for us and for various parties. And then, like I said, the shelter's role is to educate, encourage, recruit, and I will show you the data a little bit later. So next, we also have, about, I want to say 50, 60 shelters that have site-based clinics. Some of those site-based clinics are not federally qualified health centers. They are, a nurse or a nurse practitioner going, 1 to 2 days a week. They don't have the ability to use a minimum number of vaccines. So we focus on working with us larger federally qualified health centers, Care for the Homeless, for example, Care for the Homeless New York, Project Renewal, Janian, and others. And so those shelter-based clinic are, basically I reach out with them, see if they would be able to use a minimum of vaccines per week, of Johnson & Johnson vaccines per week. We put them in contact with the Department of Health to arrange their account, their training, their allocation, and including we're also providing vaccines to Janian Medical Care with their outreach medical providers, similarly with Johnson & Johnson, given that obviously the single-dose vaccines make sense for our street medical providers. We are currently, I didn't mention, but we started with 4, we now have 2 isolation hotels still, we have 2 quarantine hotels, and we are, we again are working with the Department of Health to get them immunization accounts so they can offer vaccination at a little bit before the end of the isolation and quarantine period before they leave those hotels. And lastly, we are, all assessment shelters have clinics. So we've been talking to the clinics about offering vaccine at assessment. It's a little bit harder because they see on average maybe 10, 15 people a day. We don't have single dose vial, so how do you open a vial if you're not sure we're going to get 5 people? So that's a little tricky. But we are going to, we are planning vaccination at intake. A single man intake center receive more than 50, 60 men per day. We have been offering we've been offering testing through per diem nurses since August at intake. So every client that arrives at intake is given the choice of testing for COVID or being quarantined for 2 weeks. The vast majority agree to be tested. They then are quarantined for a day or 2. Our turnaround time is very, very short at intake and in general, but at intake we use the DOHMH public health lab. We get the result within a day. And then if they are negative, obviously they go to an assessment shelter. If they are positive, they go into isolation. So we have clinics at the single main intake. The assessment sister shelter has a clinic. So we've been working with that clinic and our per diem nurses. The plan is to work with the per diem nurses to advertise and encourage vaccination, and then use the clinic to offer vaccination. Very, very informal verbal survey of clients over the last week or so showed that clients at intake are very interested in the vaccine. So we're very excited about that. In deploying vaccination at intake is going to make a big difference. Next. So as of last week, we've fully vaccinated almost 5,000 people. I think it's probably 5,000 people by now. As of yesterday, we've put more than 10,000 shots in arms. That's not 10,000 people, that's 10,000 shots. So with Moderna, again, as of last week, we've given 3,331 first dose to staff, 1,239 to clients. We've fully vaccinated over 1,500 staff and almost 700 clients. So obviously it's a little bit more now. And with Johnson & Johnson, with Johnson & Johnson, like I mentioned before, we prioritize clients over staff, excuse me. So we vaccinated, and they're obviously fully vaccinated, more than 2,000 clients and over 600 staff. Thank you. Next. So what are our gaps? So the family with children site that are not congregate, obviously are not part of the on-site vaccination. If they have, and they are not yet eligible in New York State, but if they have anybody over the age of 60, in their midst, and anyone with chronic medical condition, we are telling them that they can schedule to come to the DHS pod. Obviously, we've been telling them that they can go to any of the DOHMH city pods. The unshelters, while we are working with Janian, with outreach providers to provide vaccines to unsheltered individuals, it's obviously harder. But our biggest challenge is really vaccine hesitancy and refusal. It's huge. We have the ability with our medical providers on site to easily provide several hundred vaccines, even 1,000 vaccines per day at our sites. We could do 5,000, 6,000 a week. So that's what we are capable of doing, but with vaccine hesitancy, we are nowhere near that. So that's really our biggest challenge. Next. So what are we doing about vaccine hesitancy? We've been talking to the Department of Health, their engagement staff, their medical vaccine specialists, their ethics consultant about when can we do. So we have, right now I'm waiting for a little bit of relief with my staff to be able to dedicate a team to work with DOHMH on vaccine hesitancy. But also we've been planning a vaccine hesitancy survey. It's a two-part survey. We're going to be targeting both staff and clients. We're going to deploy it at a large number of facilities. We've done key informant interviews first, and then we developed the survey. It's going to be in SurveyMonkey for staff and SurveyMonkey in paper for clients, because we know some clients don't have the ability to do an online survey. We also developed a short-based text survey with maybe 4 or 5 questions that we are going to deploy in different shelters. We're going to target different shelters, and we're going to target a wide swath of shelters, different type of shelters, different types of sites. The content of the survey is obviously belief, experience, practice on COVID itself, the vaccine, the COVID vaccine, their source of information in education. And we're going to then use that to try to target more specific education sessions. Next. So how can you help? Education and awareness, encouragement, wherever you are in New York City, whichever population group that of homeless individual that you're encountering. Obviously, if you're a medical provider, please vaccinate them. If you're not a medical provider, please educate them, provide all the encouragement that you can, and let them know that they can receive vaccines at their shelter. We are offering both at the hotel and at the shelter. And if you are vaccinating our clients, please provide them a vaccination card. We are aiming to really try to get all information we can to measure how well we are doing. With that, I think that's my last slide. And thank you. We'll be happy to take questions, I guess, at the end. Thanks, everyone.
Thank you, Dr. Laraque, and I will, I'm Jim O'Connell, by the way, and I'm from Boston, so I feel like the outsider, but I'm going to briefly show you a few slides that just kind of summarize what we are, and I am mostly here to learn from all the amazing things you are all doing in New York. But let me start here. It was exactly 1 year ago today, by the way, that we had our first COVID positive test in the shelters of Boston. And we, like you, have most of our homeless people in shelters. About 5 to 10% of people are unsheltered, 90 to 95% are living in shelters. So we were very worried about what COVID was going to do to people living in congregate shelters. And we began by, as most of you did, by testing. This is one of the testing sites. We tested every single person going to any of the shelters of Boston. And back in those days, you had to have, this was screening. And we had to, in order to get a test, you had to pass the screen. So we found very few people that we would send on to screening. But when we did send them for screening, in the next slide, we had to make sure while they were waiting for their test result or for the test to come back, they had a place to go. I'm sorry, can you advance the next slide? And what we ended up realizing is there was no place for people to be isolated or quarantined. So we ended up initially putting up these tents, which are on the grounds of the city's shelter. And they were, tents where everybody had isolating rooms. We had separate toilets for each person. And it was really an exciting and frightening time back in the early days of COVID. And for those people that tested positive on the next slide, we needed to make sure we could isolate them for the 2 weeks that was required then. And this is our respite care facility. It's called the Barbara McGinnis House. We have 104 beds. And basically, our staff took one of the floors, 52 beds, and created a COVID positive unit. And that's where in the initial phases, back about a year or two, 10 months ago, that's where most of the people who tested positive would go. But then on the next slide, you can see we got flummoxed by the first sort of outbreak of COVID, which happened on the very beginning of April. So on the next slide, what we ended up doing is one night, the Department of Public Health allowed us to universally test everybody in our largest shelter, which is called Pine Street Inn. And on April 1st and 2nd and 3rd, we tested all 416 people going into the shelter that night. And one of them had a fever, and none of the others had really any symptoms that would have passed the screening test, yet 147 were positive. So we found we had a 35% primarily asymptomatic positive rate, and that scared us. As you can imagine, we needed to find all of a sudden places for 147 people to go. And when we subsequently did universal screening in all of the other big shelters, you can see there, the slide is busy, but you can see that 35, 36, 37% was the typical response in the large shelters, all of it primarily asymptomatic. So we had to, as you heard Dr. Laraque say, begin realizing that the screening for symptoms was not very sensitive. We had to start testing every 2 weeks. So we have been universally testing everyone going into the shelters every 2 weeks during the peaks of the pandemic. The next slide shows what we ended up having to do, and you did the same thing in New York, but we had to, our program, Healthcare for the Homeless program, which is kind of it's an FQHC, but we have a presence in 2 big hospitals where we have clinics. But this was a 500-bed COVID shelter for homeless people inside the Boston Convention Center, right next to 500 beds at Mass General, which is my home hospital, was running a step-down hospital. So this is where we ended up sending people who tested positive, most of whom, remember, though, were asymptomatic. Next slide. I say all of this because it gives you a little bit of a framework for what we had to do when vaccinations came, and I want to be quick. Interesting sidelight, by the way, the virus, the genome of the virus that went through our shelters like wildfire came directly, it was the exact virus that came directly from the initial super spreading event that was held by Biogen. So it taught us in Boston, as all of you know all too well, that we really are a village. This was a high-end conference with a particular virus that was really the initial super spreading event in our state. And all of that one virus ended up in all of our shelters. So next slide. What we have in Boston, and I just want to say as we thought about vaccinating, and everything that Dr. Laraque just said just really resonated. When you vaccine, you really require trust and consistency and presence so that people don't fear you coming in all of a sudden with a needle. So we used our network. Our program has clinics that our docs and nurse practitioners and PAs host in essentially all of the adult and family shelters in Boston, about 45 sites. And we have clinics there anywhere from 7 days a week to, in the bigger shelters, to once or twice a week in the family shelters. But we use those clinic sites as the focus for doing our vaccinations. And we only had Moderna, same as you did. So we needed to make sure we had proper refrigeration and all the protocols. But we began vaccinating about 2 months ago on all of these shelter sites, and actually started to find that the resistance or the hesitancy or whatever the right word is didn't seem to be quite so bad as we thought. And in the next slide, what we also learned is that you can go to places that are comfortable. People, I took this slide because some of the street folks would come to this church for a meal, and we would do our vaccinations right there in the church thing, and it seemed to take away some of the fear. And in the next slide, I'm trying to just go quickly, we also realized to get out to the streets where we have a pretty wild population, we needed to use our Care InReach van, which is run by Mass General and the Kraft, with money from the Kraft family. And we could put a very good refrigerator in this van and then bring it out to wherever we needed to. And this is just doing vaccines on the street with the Moderna virus, but with the Moderna vaccine. By the way, we only got our hands on Johnson & Johnson, the first doses of Johnson & Johnson, about a week ago. So I was jealous to hear about the Johnson & Johnson vaccine because that's a single dose. But in the next slide, and I'm just about finished here so that you can move on. Next slide. This is what we had so far, and it's the mandatory, you know, up to date. And this is now about a week out of date. But if you look at Boston, I think like New York, had people living in congregate settings on a top priority for vaccination. So we could start vaccinating them back in February, early February. And what we found, if you look down to the number of people experiencing homelessness, PEH, and I don't know if I can do that. I don't know if you can see that. You probably can't. But so we've been able to essentially, we've been essentially got, the number now is 61% of all the people living in the shelters of Boston currently have been vaccinated with 1 dose. And interestingly, and this is really what we're trying to think about really carefully, 77% of the people who were due for a 2nd dose have now gotten the 2nd dose. So it's been much easier to do than we had anticipated. We're now, in the next slide, now we'll finish up here, salivating over, we now have Johnson & Johnson, although not enough. And this is the street team that I work on, and you know, it's our recovery coach with our social worker, and holding the refrigerator in the rolling thing is Jen, who's our physician assistant, Eileen's our psychiatrist. But we've now been able to, as of the last week, been able to bring the vaccine, just the J&J vaccine, out on the street with us. And the next slide, you can see, it's pretty cool. You can just sort of walk down do our regular street rounds, and it's not a huge burden. And then I think the last slide I have is just, you know, we got to the, this is just on Friday, we could get to, you know, the train station, and you can start to do vaccines right outside. So we have great hope for the future that as more and more Johnson & Johnson, the single dose is available, you don't have to refrigerate it for as long, and you can do it in a portable refrigerator that size. We're really looking forward to actually doing better. I look forward, by the way, to the questions. I'll stop here. The issue that is, the 2 issues that I would highlight is 1, how to make sure we win people's confidence so that they will really get the vaccine. And 2, we are very laser focused on the equity in distributing the vaccinations. And so we follow every day, we have a report on the race and ethnicity of everybody getting the vaccine to make sure we keep ourselves in order. But anyway, let me stop there as my 7 minutes is up, and thank you so much. I deeply admire all that you are doing, and Housing and Health has been a great inspiration to me all these years, so thank you.
Good morning, everybody. So again, my name is Isaacsohn. I'm one of the providers on the CUCS Janian medical care team. Next slide, please. So I'm going to talk today about sort of just to run through some of the data for the vaccinations we've done, and then kind of get into a little bit of the nuts and bolts to how we set up our vaccine drives, and then to discuss some lessons we've learned and talk about some next steps. So I have no disclosures. So I just want to say thank you. This has been, from the beginning of the pandemic, such a massive team effort and required cooperation on all levels within our agency and with our partner agencies and with our partners in the city government, and we really couldn't have done it and continue to not be able to do it without each other. So the work I'm about to describe was created by a team of people, and I'm really privileged to represent them. So next slide, please. So before we ever did any drive, we worked really, really closely with our social service partners and our outreach partners to identify interested clients and backups. And our initial thought was to try and figure out who was already interested, and then work on establishing vaccine confidence for the remaining folks kind of afterwards. As Dr. Laraque alluded to, it's really challenging to figure out the timing of when you puncture that vial and making sure that you're going to have enough clients lined up to use all the doses, which is sort of the clock starts as soon as that happens. And so while we kind of got our feet under us in terms of logistics and the staffing and the operations side, we thought we'd kind of go after the people who we already knew were interested, and we really leaned heavily on our outreach partners to help us find those clients. Meanwhile, we were going through and we were providing trainings to our staff to give them reliable information about the vaccines, to try and build their own confidence and to turn them into vaccine ambassadors as they worked with clients on a more day-to-day basis. And then finally, at the beginning, and I'll mention this in the next slide, but we started out by just having the Moderna vaccine. And so we worked, which is sort of not transportable. It's too fragile. And we we worked really closely again with our social service partners to work on all of these staffing and transportation puzzles to be able to bring clients at times from disparate programs to our central vaccine locations. And then just, okay, so next slide, please. Okay, so to date, before we got Johnson & Johnson, we established a strategic partnership with an FQHC network who contracted with us. So the FQHC network was interested in providing vaccine to vulnerable patients, but didn't have the staffing to do it themselves. And so we were able to contract with them to provide that vaccine to our clients. And so using Moderna vaccine, we were able to, we've so far vaccinated 80 people, 40 of them fully, and the remaining second doses have been scheduled and are happening next week. And then through Dr. Laraque's office and DHS, we have been able to get a supply of Johnson & Johnson vaccine, and using that, we have vaccinated 98 people so far. The vast majority of those people are unsheltered, street-based clients, and that's really been the focus. That was the sort of the focus of that tranche of Johnson & Johnson vaccine, and really in line with our mandate as street medicine providers. Okay, so how did we go? Next slide, please. So how did we do this? And so, at its most bare bones, our vaccination teams are one screener and scheduler plus a vaccinator. Usually those two people are clinician. Well, the vaccinator has to be a clinician, but the screener and scheduler is a clinician as well. And then patient flow facilitators, post-vaccine monitors, and then a float physician. So we figured out this team kind of through a variety of things. We attended lots of webinars from the State Department of Health and from CDC, and kind of trying to figure out what the nitty-gritty and recommendations are for how these teams are. And then I've been vaccinating through the Department of Health pods as a medical volunteer, both because it's fun, but also really as I was doing it as a reconnaissance before we set up these clinics ourselves, to really understand how this works on a big scale and figure out what is necessary and how we can replicate it. And then the delay in getting vaccine ourselves actually gave us time to prepare, which it was frustrating because we were really eager to get vaccine into our clients' arms. But on the other hand, it was nice because it really gave us time to sort of learn some best practices. Next slide, please. Okay, so what do we bring to these sites? So the team as above, we bring a monitor, refrigerator, needles, syringes, alcohol pads, Band-Aids, gauze, epinephrine kits, vitals just in case, pre-vaccine checklists, HIPAA consents, fact sheets for afterwards, Sharps containers, CDC cards, stickers and music. And at the beginning, when the vaccine supply was tighter, it felt it felt weird to be bringing vaccine and not being able to say to all the clients, hey, we've got enough doses for everybody, come on down, and really make a party out of it. It felt like, it was just the people who had previously signed up. And now as our vaccine supply has gotten more steady, we're much more eager to sort of make this into a joyful event whenever we do it, as a part of building confidence, and that this is not that this is something that people are excited about. And it's really, we were reflecting on this a couple of weeks ago, thanks to the partnerships with the FQHC network and with DHS. So our clients were among the first 10% of New Yorkers who were fully vaccinated, and that's really something to be celebrated, and it's a testament to all the work that all the teams have been doing. Next slide, please. So again, this is the workflow, and I'll get into this in a moment during the lessons learned, but basically, somebody comes into the site, they're screened using the CDC pre-vaccine checklist. They fill out the state form. They get put into our EMR. They get escorted to the vaccinator. If the post-vaccine monitor is in a different location, they get escorted there. And then that's kind of the general flow of things. Next slide, please. Okay, so lessons learned. The number one lesson is it's always helpful to have a bigger team than you think you're going to need. Just the more staff, that you bring, the easier it is. Something always comes up. That float position has been really crucial. So at times that's usually a clinician, and at times it's been the person who's sort of like responsible for monitoring the flow of vaccine out of refrigerator to make sure that we're not kind of getting over our skis with the number of doses that we have sort of ticking and must use. It's also been helpful to have, in case somebody screens positive for not feeling well that day, it's helpful to have a clinician who can sort of pull that person out of the flow and deal with whatever medical thing they've got going on. And then just continuing, and I think, the street medicine approach and really the approach of all of our provider partners is one of a lot of flexibility, and, just be prepared to be flexible. You could have 5 clients lined up for a 5-dose vial and 5 backups, and all 10 could not show up, and the best laid plans kind of can go wobbly really fast, and the teams have to be prepared to pivot and sort of make good. You have to have a good reporting structure, but a good confidence in the team to be able to make good decisions on the ground. And then really, I think one of the key lessons that I'm taking away from this is just how crucial existing partnerships are, and how important it is to look to new partnerships. And as we now have this steady supply of Johnson & Johnson vaccine through DHS, we're looking in Manhattan, Brooklyn, and Queens to partner with new groups who work with street-based clients, so that we can be the vaccine provider, and then to also bring our outreach partners, our existing outreach partners, along with us, and be able to use these vaccinations as a way of sort of forging new connections between outreach providers, new social service agencies that might have popped up during the pandemic, and clients that the outreach providers might not necessarily have a way of accessing beforehand. And then in terms of vaccine hesitancy, we're really trying to build vaccine confidence. Sorry, I added this one just in my notes. We're really trying to build vaccine confidence among both our staff and our clients. And so we are giving presentations to staff all the time. We're really trying to turn them into ambassadors. And then I think, I imagine other people can speak to this experience, but as more and more of our clients get vaccinated, and those that have been hesitant or sort of wanting to hold out see their friends and their co-residents being fine and getting a vaccine, we're hoping that there's going to be this snowball effect. And I really, the partnership with DHS and being able to know, the addition of vaccine to the ongoing testing schedule is such a good idea, and it's been really helpful for us to know that schedule. We work closely with our DHS partners and to sort of be able to buttress that if they're going to be at a safe haven, on the Friday, then we know that that's a place where we don't necessarily need to see if those clients need vaccine for that week. So I'm looking forward to the question and answer. Thank you.
Hi, everybody. This is Irene. Thank you so much for letting me be a part of this. I am honored by the other people on this panel, and I'm excited for the Q&A. So I'll try to keep it brief. You can go to the next slide. I'm a primary care doctor. I work at the Bellevue Safety Net Clinic, which cares for folks experiencing homelessness. I also, a little bit separate from this talk, but some overlapping, I also work in the psychiatry clinic doing primary care for folks experiencing serious mental illness or mood disorders. So I come with that framework and those interests. I did some data gathering over the last few days, looking through our charts. We have about 6 or 7 primary care docs that work in the safety net clinic, and we have about 200 patients. So it's a very small sample size, but I was able to pull this information on our vaccination rates, and we'll go into some of the barriers and some of the things we've tried to do, but it's been really tough, I think, from a primary care doctor's perspective, but things are starting to look better. Things are on the horizon. It's great to hear about all the efforts that are happening at DHS. I guess I'll just highlight here that the New York State rate for everybody living in the entire state, not just folks experiencing homelessness, is about 26%. I looked it up from yesterday. Are at least partially vaccinated, and 14% are fully vaccinated. So, we have, I should say that at least partially vaccinated is 26%, and then within that is the 14% fully vaccinated. So our numbers are close to a quarter of our patients so far are partially vaccinated. I think this will get better as we get J&J. And then a lot of our notes don't comment on whether patients are interested or not, but I will just point out that there are already a stable number of patients who are just outright refusing. And I think, you know, there's a lot of opportunities, especially because they're closely connected with us in the clinic, to try to work with them on some of those things. But that is going to be the next frontier, as everybody is alluding to. So next slide, please. So what have we been doing and what are we trying to do going forward? So I would say that about a month ago, it was kind of like the Wild West, and we were trying to get patients. We didn't have the ability to book patients at Bellevue, even though there were appointments down the hall at Bellevue, which was difficult. So we were booking patients at the New York State websites, Yankee Stadium. I put together a Google Doc guide for the primary care docs that work at Bellevue to try to call all the information we were able to get about where patients can get appointments so that everybody could have the most up-to-date information about eligibility and also opportunities. Luckily, a couple weeks ago, we now are able to do same-day vaccine appointments some days of the week at Bellevue for Pfizer. We still don't have J&J at Bellevue or in clinic. And then I think, you know, there are a lot of things happening at DHS and other organizations in the city. We often are not aware of when those are happening or when they're happening in the future or in the past until a patient comes in and says, "Doc, I got my J&J last week at my shelter." So that's just kind of, they pop up here and there, and it's happy news, but a little hard to anticipate for us in the clinic, at least. So in terms of barriers, a lot of things, I would say one that hasn't really come up a lot today that I'll highlight are literacy and tech and language barriers, as well as transportation barriers. One that I'll point out quickly is that, for instance, a lot of patients want J&J, they want that one shot. There were, a couple weeks ago, there were overnight appointments at Javits for J&J that we were able to offer people appointments to, you know, through the online portal. However, the subway is not running 24/7. And also a lot of patients were concerned about, you know, am I gonna lose my bed? What are the shelter rules about this? And we didn't really have a way to adequately reassure them in the moment. So they were hesitant to book some of these overnight J&J slots, especially with those two barriers. That's just one example that's come up recently. For the same day appointments at Bellevue so far, the way that the shipping comes in at Bellevue, literally they come in on Monday. I happen to be the Monday morning clinic doc. And so we can't do same day appointments because they don't know if the shipment will have come in. So they can do same days on Tuesday, Wednesday, Thursday, Friday, but we can't do same days on Mondays. Again, we also don't have J&J yet. So those are just a couple limitations. Okay, sorry, next slide. I'm just gonna put a couple quotes up there you guys can read. I think one that was particularly heartbreaking, a patient I know very well with cirrhosis, who is very much someone who would do anything that the doctor told them to do, kind of thing, which is always a little intimidating and scary at times, but he would definitely be someone who would want the vaccine. He wanted to talk to me about it first, but they had already come to the shelter the week prior to our appointment, and he didn't know and I didn't know when it would be offered again. And this was at a time we didn't have it yet at Bellevue. So just to highlight a couple of barriers that come up. And I put the puzzle there because sometimes I feel like this patient lives in Brooklyn and so they can go to the Medgar Evers state site, but you know, they can't make it on Tuesdays, and it just feels like you're kind of a hotel concierge trying to navigate all these different resources and all the barriers with the patient not necessarily being able to pay for minutes on their phone that week that you were able to get them an appointment the following week. So I'm just trying to say how it feels from the clinic is kind of what I'm trying to paint a picture of. Okay, next slide. So I think a lot of you are probably familiar with the Swiss cheese model, and it's intended to be used for preventing bad outcomes, but I'm gonna flip it on its head and use it as a picture to show how it sometimes feels to get a vaccine to a patient. So say there's an available appointment, you go through all these barriers to get to that shot in the arm, not to mention that you have to do it twice with 2 of the vaccines out there now. So if you just click again, you'll see, if you could just click one more time. You'll see some of the barriers that I'll point out, some of which have already been mentioned. But what I'll say is that I think the first barrier can't be ignored, that we have to rely on staff bandwidth, whether it's the doctor, the front desk staff, care coordinators, nursing, other people in our team, to even know there's an appointment. And then, going through all these other holes in the Swiss cheese to get to the actual shot in the arm, can be really challenging. And this is how it often feels for us as the little doctor in the little clinic, outside of all these other structures. So next slide. I'm trying to keep to my time. Okay, so you can just click the next couple images, please. There should be 3. So how do we make it, what I would love is that there's people not necessarily overwhelming the patient, but coming from a lot of different angles and giving patients lots of opportunities to get appointments. It obviously shouldn't just fall in the shelter. It shouldn't just fall in the street team. It shouldn't just fall in the clinic. All of these things should be coordinated, and there should hopefully be more availability and more clarity on when the availability might be in the future. And I think a couple of things I'll highlight is that the walk-ins, the place-based appointments in the bottom left, that I think those are just really critical, because it's so hard, especially for people experiencing homelessness with all these barriers. Unless someone comes to them with a shot, it's going to be really difficult. So I applaud all of your efforts, and I think they're so important. And then I think the other thing I'll highlight, as someone who's a little biased working in a psych clinic, I think psychiatrists, therapists, and other substance use providers, I think all of those are uniquely positioned to help with some of the hesitancy and also some of the barriers if the vaccines are available in those clinics, especially ones that already have nurses, like a methadone clinic or dex shots with nursing staff. All right, next slide. Okay. So if I'm gonna dream, I would dream that we'd all share a computer system where we could all communicate all these things and avoid duplicating our efforts. Again, the walk-ins, using psychiatry clinics and substance use clinics. And then I think one other thing I'll mention that hasn't really been brought up is that I happen to commute 1 hour each direction from Upper Manhattan into Midtown, taking the A to the L for those of you who know New York, and then walking from 14th Street up to Bellevue in the 20s. And you would have almost no idea that we had a COVID vaccine based on public-facing advertising on subways and on NYC Link advertisements, which I find really difficult, that so much is being put on community teams and doctors. And I think more needs to be done that's public-facing, that doesn't rely on people having Instagrams and phones and all these social media accounts to know not only who's eligible, but the fact that there are 3 vaccines now, and just more information about that would be great. Okay, so I'm definitely at time, so thank you.
Hello, everyone. My name is Julian Watkins. I'm a excuse me, internal medicine doctor at the New York City Department of Health and Mental Hygiene, and I'll hop right in for time. Next slide, please. We like to start out our presentations by kind of giving an overview of what's going on in the pandemic in New York City, and starting with the image to the left. That's what we call a heat map. And so it's the 5 boroughs broken down in zip codes, and it's color coded. So the deeper the colors represents a higher 7-day testing positivity. And you can see the distribution across the 5 boroughs, that it's not equally distributed, the burden of the infection. And it really just highlights where there are still areas where there's a need for testing and increased testing and continued testing, but it also can guide where we are focusing our vaccine efforts. If you look to the right of the screen, you can see what we call the epidemiological curve. It's zoomed in for this second wave that's been called more frequently. And you can see starting from December all the way through March, where we were towards the beginning of January, you can see where we had a peak. Where some of our daily case counts were in the 7,000 to 8,000 range. If you follow that solid blue line that goes across the image, you can see the 7-day average. And if you look to the far right of that image, you can see where we are on the curve. You can see where the line is pretty flat. which means we're not going up or going down. And currently across New York City, the percent positivity rate is about 7%, a little bit lower than 7 citywide. But if you look to the left again, some places are in a deep red and are up to about 10%. So we're still in the midst of this, of this second wave, and we're in a very crucial point in the pandemic in our city. Next slide. All that said, we're here for vaccines, so we'll talk about vaccines, but I think it's important to keep that context in mind. Next slide, please. So I like to talk about the vaccine numbers and give a little context to where we are citywide. So I start with the yellow number in the middle. That is the number of folks who have gotten the first dose of the vaccine in New York City. These data are from yesterday. So more than 2.3 million folks have been vaccinated in New York City with the first dose. If you look to the number below in the blue, you can see that 1.2 million adults have been fully vaccinated. So in total, that's over 3 million vaccine doses administered in New York City, which is larger than the total population of a city like Chicago. So we're doing a lot of vaccinations, a lot of vaccines are going in arms. The number to the top of the screen is important because that represents all of the vaccines that have been delivered to New York City. First and second doses of the mRNA vaccines, but also the Johnson & Johnson vaccine. As we go a little bit further in my presentation, I think it's important to highlight that if we had our way, we would have vaccine available, and the vaccine supply is really the thing that's limiting our efforts and making things so much harder, just because at this point, the supply does not equal the demand. Next slide. So talking about the New York City vaccine program, we're calling it Vaccine for All. Our major focus is on equitable distribution and really acknowledging the history and current experiences of racism and bias and exclusion in healthcare and how communities that have been impacted by COVID have been impacted by a lot of other social ills. So we're working to make sure that we ensure both access and confidence in the vaccine. And this, the brain center for this operation is called the Vaccine Command Center. It's an interagency operation. So folks from the New York City Department of Health and Mental Hygiene, folks from Health and Hospitals, Test and Trace Corps, New York City Emergency Management, and other city agencies are all working around the clock on improving our vaccine program and making sure that we can ensure access and work on confidence. We are also working with partners in the federal level, in state government, elected officials, and other folks in the other sectors in the communities. Next slide. So when we talk about messaging, some takeaways that we'd want everyone to know around the vaccines is that the vaccines are safe. A lot of folks do have their concerns, and just really explaining and being really transparent with folks and letting them know what the process has been, familiarizing ourselves as healthcare workers and advocates around the process of the emergency authorization, and really doubling down that no safety measures were, no corners were cut in the safety and testing of the vaccines that are available. Regarding the vaccines are recommended. So the messaging is everyone who's eligible should get vaccinated, understanding that even if you have had COVID-19, even if you have had antibodies, we know that sometimes the antibodies do wane. We also want bringing that message, helping people understand how important vaccines are, and asking the question, how do pandemics end? One of the major public health interventions beyond clean and sanitary water has been vaccinations. When it got us out of polio, it's gotten us out of smallpox and a few other vaccine preventable illnesses, and really having folks understand the importance of vaccines. Another major vaccine message is messaging around the vaccines that are available. So the vaccine, and doubling down that vaccines do not contain the virus that causes COVID-19. Early in vaccine world, people were concerned about these mRNA vaccines because it's new vaccine technology, and just taking the time to explain to folks that the mRNA vaccines are built, that the current mRNA vaccines that we have for COVID-19 are building on a lot of medical knowledge and scientific advancement, and people were concerned about the speed of the release and helping people understand that that's like a reflection of the times that we live in. We have scientific advances, and it's the real testament to human ingenuity and what we can do if we put our resources and come together as a society to really focus on major societal problems, such as a pandemic. And then just the basic message around vaccines do not alter DNA, and helping people understand a little bit where we're coming from and explaining what mRNA is. A lot of folks may not be familiar with mRNA as another basic building block of life. And also talking about the new Johnson & Johnson vaccine, letting folks know that viral vector technology has been in use for a bit longer than mRNA, and even for like the Ebola epidemic, for example, is a thing where we're using the same technology to treat for Ebola vaccines, which are out in the public. So talking the vaccines that are currently available, Pfizer and Moderna, these are the 2-dose regimens. We're recommending folks to stick to the 21-day follow-up second dose for Pfizer, but up to 42 days. Then, helping to allay any fears that folks may have if they don't make the appointment, to try to reschedule to make sure that they get that second dose within that 6-week window. And for Moderna, it's 28 to 42 days. Johnson & Johnson definitely represents a great advancement in really improving access to vaccination, because the adenovirus vector vaccine is a more stable product and it doesn't require some of the same temperature storage requirements, and it's a lot more mobile. That's a game changer. Being able to take this vaccine out to folks who are not able to leave their homes, but also folks who don't have homes and don't have stable housing. The Johnson & Johnson vaccine, though the supplies are low right now, in the coming weeks to months, we'll see the weekly allotments that come to New York City increase, and hopefully appointments and ways that we can get the vaccine out to the community will increase as well. And then other messaging around vaccines is letting folks know that even if we get vaccinated, they still have to, continue wearing face coverings properly. There's new guidance around double masking with the surgical mask as a first layer, and wearing a cloth mask over just to have a more secure fit, but also trying to maintain physical distancing as much as possible, and limiting gatherings that are not necessary. Next slide. So the phase distribution and eligibility, all of this depends on the supply. In recent weeks, we've seen a lot of the eligibility criteria opening up. Early this week, we saw that people 50 and older are eligible, but then there's a lot of other folks who are eligible on the screen. I won't bemoan the point. I think also understanding folks who are affected by homelessness, that children are a major part of the population, and there are studies underway for people 12 years and up, and also a recent study underway for people 6 months and up. So in the coming months, we'll see vaccine information and data around children as well. Next slide. And not to get too deep, because I know people have burning questions, just talking about how we're building confidence. And again, it's about equitable distribution and letting folks know that we are trying to reach them, and we have programs focused on reaching communities and enhancing our access, but also building that confidence and understanding that what is termed as hesitancy is actually a reflection of folks who don't have confidence in systems that have failed them, especially for folks who are experiencing homelessness, understanding that people's needs, people have to weigh their needs and their concerns. And some people can't put food on the table, getting vaccinated or making that appointment may be the last thing that, the lower on their priorities. So just understanding that and speaking to that, and really trying to understand where people are coming from and speak to their individual needs, and avoiding labeling folks and pathologizing folks for their deeply personal decisions. Next slide. This is the end, but basically just focusing on the core 4 strategies, while as part of an overall toolkit and approach to control the pandemic: staying home if sick, wearing face coverings, physical distancing and washing hands, getting vaccinated if eligible, and also spreading information and share, and as stated earlier, for folks who have been vaccinated, to share their experiences and share their stories and how they came to decide to accept the vaccine. And with that, we'll wrap up.
Thank you all very much for those presentations. I do want to go right into the questions so that we'll have answer as many as we can. The first actual question I have will go to Jim O'Connell, Dr. Jim O'Connell, Dr. Lee Isaacsohn, and Dr. Irene Swanenberg, those that are sort of at the forefront giving the vaccine out. All of you mentioned approaches to overcoming some of the unique barriers, overcoming the hesitancy, overcoming other barriers to getting the vaccine to the homeless population. Jim talked about trust, consistency, and presence. We had from Dr.
Is it just me or did the audio go out?
No, yeah, the audio. Oh, there you are. We lost you there for a minute, Dr. Foster. Do you mind repeating the question, please?
Sure. So for these different approaches to improving access, what would be anything that you wanted to add to how you sort of overcame these hesitancy issues and obstacles to vaccines that were unique, that you felt were particularly effective? If there's anything you wanted to add, and then how do you balance that with the challenge of things that you did that were successful to minimizing waste of the vaccine, which fortunately I think will be less of a problem going forward, but is still something on everyone's mind. Anyone from,
Yeah,
Lee?
I could jump in and say something really quickly. I think that we found that people seem to be much more likely to say yes when the person giving them the shot is somebody they know. And I think it turned out to be kind of interesting for us. The other problem though that you're bringing up, and I think we've all faced this, is once you open a vial, you've got to be able to give all, if it's Johnson & Johnson, all 5 or all 12 or 11 of the Moderna. And that was a huge challenge because you only had a little bit of time to get those out. So we had to sort of stage it so you had to wait till there were enough people there before you really started giving it. And that was a barrier, which we really look forward to the days when that's not such a barrier. And with Johnson & Johnson, that's less of a problem. But anyway, just to throw, I'm sure others have other ideas. Those are 2 thoughts I had.
We've been asking people that have agreed to get the vaccine to speak about their experience with others and to sort of to outline the decision-making process. And we've just, and whether that's staff or their clients, for the people who are sort of taken, oh, this is a no-brainer approach, I'm going to get this vaccine, to sort of explain why they thought that to other people. And we had an experience the other day where we had some vaccine that was on its way to spoiling, and the clients that we had arranged and the backups didn't show up, and so we were offering it to staff members, and we had a 40-minute conversation with 4 staff members. Afterwards, 2 of whom agreed. And after we administered to the second person, the third, one of the third remaining staffers said, okay, well, if those 2 guys got it, well, then I'll get it too. And we sort of said, well, we don't have any more vaccine for you, but we'll help you make an appointment. And I think that there really is going to be this snowballing.
Mm-hmm. Mm-hmm. Okay. And is this then we turn again to the sort of information and misinformation, how we give correct information to clients. One person asked online, one of the things that they came across was that people who are living in the hotel shelters, they were concerned that if they got the vaccine, somehow this would now prompt them to be then shifted back to general communal shelters. And is that something that has been, it has any kind of policy around?
Hi, thank you for the question. No, we have heard the same thing also. And I think one of the things that happened, I think totally we transfer client once in a while for whatever reason, if something happened at a shelter. And I think somebody who was vaccinated was transferred completely unrelated, and that might have fueled some of the misinformation. But no, we don't. We are specifically not linking return to congregate shelter with the vaccine. So it would be great if you can help share that information. But yeah, there is no policy, or rather, there is a policy of not doing that specifically.
Okay. Yeah, and this really leads into the next question for you guys. Is the communication, right? Is the coordination, the database? How can we best? What are the plans for just maximizing access of information from as we coordinate between city-run agencies and private agencies and hospitals? What's the future for the coordination of information? Because so many of the questions come up about, there are certain, clients have a huge spectrum, those that keep track of it and tell you, but then there's a large number that are a little more disorganized. And I know from the emergency department, we're very concerned about patients who are a little bit more disorganized. How do we understand their vaccination history? What's the easiest? What are plans for that?
So, I mean, I can start, maybe DOHMH can continue, but every provider that administers a vaccine must enter the vaccine information into the citywide immunization registry. And so that should be available in real time, unless they're batching the data. And then prior to immunization, any provider before giving the vaccine can look into the registry to see if that person has been vaccinated already.
And how does someone get access to that? I don't know if someone in the private hospitals would have in a private office. How would they access?
So it's something that every pediatrician, every pediatric clinic has access to. It's like completely standard because reporting of immunization for children is mandatory. So if anybody here was a pediatrician, they would absolutely know that. For adult, it's not the same, because reporting of vaccination for adult hasn't been mandatory, but it is for COVID. So in order to get the vaccine from the Department of Health, you have to actually have a CIR account. You have to register and you have to report your vaccination. So if you are signing up for vaccines, you're entering this information.
Okay, and so that's great that it's there. How do people access it who have not done it before? How would emergency departments, for example, or a doctor's office, who's adult?
I can speak to that as a. I mean, it basically pops up in Epic or in any electronic medical record that you use. You have to, as with everything in the medical record, you have to click like 20 things and refresh it, and then it'll be there. And there's like a week, sometimes a 2-week delay, because I have patients who have gotten, especially at New York State-run locations, I see their card, and they have gotten the shot, and I believe them. And it's not in our database yet. So especially with the state-run sites, after I went through these 200 charts last week, I can speak from experience with some patients, and other sites, especially hospital-based sites and a lot of the DHS sites, in my experience, like it seems to upload right away. I don't know why there seems to be a delay with some administration. Yeah.
Okay.
On the city side, it goes very, very quickly. I mean, our EMR is now linked to the CIR, and by the time I click it in our EMR, by the time I close the chart and open up the CIR, the information is already there.
Okay.
And if you were a mom and pop clinic that wanted to give vaccine for whatever reason because of your population, you can get a CIR account. So any physician can get a CIR account.
All right. And however, so the next question is eligibility, in terms of access and eligibility. Some of the questions involved for the city, is there any restriction in terms of people who don't have, who are undocumented, for example? And then the other question is for homeless patients, not at all. And I just want to clarify that. And then for homeless patients, are we saying that they still have to meet the other eligibility requirements in terms of comorbidity disease, or are we saying, is there any thought to having, if you're homeless, there's enough of a risk factor for that we wanted to vaccinate anyone in a shelter who says they want the vaccine?
So we don't make the eligibility criteria, the state does. So what the state says is if you are in a congregate setting defined as having shared facility, you are eligible regardless of age, regardless of comorbidity. But the difference with the family with children shelter, and I saw there was a question about that, is that they are not technically congregate facilities because the families have their own room and bathrooms. So the 10 or so family with children shelter that have to share bathroom, we consider them congregate setting, and we're offering vaccination there. So we will follow once the state open it up to, you know, as we like everybody else, we follow what the state says, and if the state open it up, we'll but so at the family with children side, if there are anybody who is meet the other criteria, then they can obviously get vaccinated too.
You know, if I could throw in that this is something that has divided our staff and our morals completely, because people in congregate shelters, we could vaccinate. We were vaccinated like crazy. The people living on the streets, which are the people we take care of, and I'm curious about Lee on this one too, were not eligible because they're not in a congregate setting, they're outside. So we were in the middle of vaccinating people that happen to live on the street. They weren't technically eligible. So we had to rely on our own. It was really hard not to do that. And we are just grateful now that, you know, as we still have to, for those people living on the street. Incidentally, by the way, just as a curious thing, I'd love to know your thoughts later. You know, we've been doing testing, you know, we've done thousands and thousands of tests. We have yet to test anyone on the street who lives really on the street who's turned positive ever since the thing began. So it's not a high risk group, interestingly, but we certainly want to make sure we get them vaccinated. So it's a real dilemma for the clinician. You've got the shot here, but they don't quite help.
We have also not had anyone that we've tested on the street turn positive in our testing. I think the way that we've rationalized vaccinating street homeless-based clients is that they participate in congregate facilities for eating and sleeping, and in bath. Sorry, not for sleeping, but you know, so they're sleeping in a congregate setting if they're in an encampment, and they're sharing bathroom facilities when they do come inside to drop-in centers and things like that.
And I can say, speaking from my experience as a primary care doc at Bellevue, we have a unique position where most of our patients have a qualifying medical condition. I think there's none of those 200 patients who don't have obesity, hypertension, cancer, prior cancer, asthma, hypertension, the whole list. So a couple of them have jobs in grocery stores or bodegas too. So, I mean, basically I keep asking until I find a qualifying condition for those guys, because they all have one, if you just keep looking. So that's my experience. Plus it's 50 plus now in New York, so yeah.
Right, that's right. And we offer vaccination in our drop-in centers also, where people don't sleep technically, but they've been part of our testing routine, and we vaccinate there. We vaccinate at stabilization bed facility, which are facility recently open since COVID. So anybody from the street can come in, and if they sleep there, they are eligible, because even if they don't sleep there every day. And again, I would agree with Irene and Leah. Street homeless population has a lot of chronic medical conditions, so they are eligible by virtue of the other characteristics.
I would also, I would just also offer that the eligibility criteria for all adults is going to open up again probably in the next month or two. So hopefully this is a very limited problem, you know, for the next few weeks.
So brings up another question. How are we sort of assessing the outcome of this? In New York City, which is just orders of magnitude greater problem than most other New York cities, do we have a sense of what percentage of the homeless population has been at least initially vaccinated? You know, and where we are in terms of what our goal is for the number of patients, number of clients?
Yeah, it looks like we are about 12%, and I think, isn't the city at 10%?
No, it's 14% fully vaccinated for 18 and up.
So, you know, we started much later in the city. We literally started on site 2 weeks ago, 2.5 weeks ago. So we have about 12%. We are again, I think maybe it was I can't remember who mentioned that, but we look at our data. We report every day. We look at our data, and we have a weekly more detailed analysis with demographic. We by shelter, so we are tracking the rates by shelter. We have one shelter that vaccinated 48% of their population. We reported that they, but others is lower. But with data, we are tracking that, and we'll continue. And this is not a one-time vaccination effort. We will come back every 4 weeks with both testing and vaccination.
Very good. So, and then last questions, in terms of the data then, are we able to collect data on race, ethnicity, so that at the end we can answer people's questions and concerns about disparity?
Yes, we are at our shelter-based site, almost half are African American, and a third are Hispanic. It's sort of matched the profile for population. We still have some unknown, but yes, we are tracking that information, and we're just starting analyzing. We have data cleaning to do still, but yes, definitely tracking that for us.
Yep.
Okay.
Citywide, about 17% of folks aren't giving that data, but there's a large, it's coming in the citywide, it's pretty good data.
All right, and then we've heard some of the mobile vaccination. What are the plans for expanding? Do we think that this is one of the main answers to getting the numbers up? Are these mobile vans and other mobile ways of getting the vaccine out? Is that something that's expanded, or is it that is just going to be a part of a lot of, with other things as well?
It's going to be a part of a lot of other expansion efforts. I think it's really, the focus is about building the infrastructure for when the supply does come in, that folks will be able to hope, the pharmacy programs are expanding, some of these mass locations, trying to get it to other like facilities, FQHCs. It's like a broader expansion for infrastructure.
Okay. But you do expand, you think that mobile vans and such will be a big part of that, or?
Yeah, so there are mobile vans that are out for particular populations right now because supply is so limited. But I think it's something that we've been relying on for citywide testing efforts, and people have been using it for vaccine as well. But I mean, the supply is like really low. Like for Johnson & Johnson, for example, New York City will get like less than 50,000 doses in a shipment.
And how does one overcome the idea that when you use more of these sort of mobile options, the idea of what information is entered into the immunization records, the statewide immunization records, that allows you to track accurately these patients? Is that a challenge or not?
That's most of these. A lot of the mobile units are run through health and hospitals, and if they don't have Wi-Fi on the vans, usually what would happen is they'd probably like upload at the end of the day. It's like it's depending on who's running the van, they work out that process. But even if it's like paper and someone just inputting the data, it may be something like that.
Okay.
Yeah, the information that's reported to the CIR is name, date of birth, race and ethnicity, and then borough, and then which arm it went into.
Okay. All right. So last question then, as we wrap up, would be lessons learned. If there's anyone has something that they would have done differently as this evolved, this is an opportunity to talk about it. Otherwise, just let me know. Let us know.
Yeah, I have one thing. I didn't know there was a pod site for DHS patients. So we have a lot of DHS patients, and we didn't know there was a way, like a designated spot that wasn't necessarily associated with their shelter. And I've been texting with other people in our clinic, and we weren't aware of the Jack Ryan site. So that's fascinating. And I guess we'll reach out, but it's been up for 2 months, and it would have been nice for us to know about.
So if I can answer that, yes, please feel free to email me. But it was a closed pod. So it was a DHS closed pod. So, and in order to make sure we don't waste vaccine, we couldn't just opening up to whoever wanted. So we had to have shelter schedule and make sure, so we would know who is scheduled, how many people are scheduled, how many vials we need, and how many vaccinators we needed. So it was a whole operation to make sure that the vaccines were really used and that the vaccinators were busy, and that we had enough for the day. But right now it is going to be opening, because we have the on-site vaccination. It's also open to anyone, any client who can get themselves to the site and make an appointment on their own. And I believe the appointment is not like the city, 17-click appointment system. It's pretty simple. So we can definitely talk about how clients can make appointment directly from now on.
And is that a phone number or a website, or how? I guess we'll talk offline. It just seems like something that
it's a link.
Distribute, yeah.
And that's one thing that did come up, though, is the idea that so many of our services are for people with smartphones and computers. and the idea of how do we, for those that need it, have something, either a walk-in or a phone number that could allow them to access these kinds of appointments, especially for same-day appointments or next-day appointments, is something that seems to be a big challenge for as we get closer to trying to get closer to 100% of those in the homeless population that we can, and for the whole population of the city, is for that matter.
Yeah, I totally agree that there is a barrier. Just a note though, at our site, the shelter director or the director of social services, some staff helps the client. They actually make the appointment for the client whenever it's necessary. And if you see someone at Bellevue and you need a mechanism for them to make an appointment, you know, we have to think about how to do that if the person is not able to make the appointment themselves. One of the things with the city pod is we cannot, it's been hard to manage a large group of perhaps mentally ill, perhaps disabled clients that need help. So we require that the shelter staff come with them to help them navigate. And someone that has limitation would be unable to come alone. And that's also one of the reasons we have the on-site pod. So if you need assistance getting vaccinated at your shelter, seems to make more sense to me. And then the Jack Ryan pod is folks that are more independent can use it. I don't know if that makes sense, right? There's a different population, different needs.
This highlights how important embedding equity into these systems that we build is, and making sure that we make access, we consider a lot of other people's needs in terms of access beyond just get on a smartphone and get an appointment, because so many people who live in New York City don't have the technology or the access or the understanding or the mobility, and just really trying to make a broad way that people can get these vital life-saving services.
Yeah, I mean, I can't see how better to do it than bringing vaccines to the shelters. It's in their cafeteria, it's right there. If their shelter is accessible, that means they're gonna be able to access that room. It's there. And we are there for many hours.
Is there a schedule with oh, sorry.
No, I'd say with more Johnson & Johnson, that will be something that can be a lot more possible. Unfortunately, the mRNA vaccines, they're just not as mobile, and that was a major limiting factor. But as new vaccines become available, it's encouraging how we can actually use them to meet the needs of New Yorkers.
All right, I think that's it. So we can wrap up on time. Amy,
There was a
thank
question
you all.
about schedule, if I can answer the question about
Yeah,
schedule.
is like future DHS appointments, like if I knew my patient was in the X shelter and they could get it next Tuesday, like that would be.
Yeah, so we go every 4 weeks. So it's roughly about the same time. So if you see some months have more days than others, so it's roughly about the same time. So, you know, on a cycle, but we don't publish this. If you know a client needs a vaccine, then they should talk to their shelter director or their case manager, and they'll be able to tell them about when. It's a very expensive proposition. I did not mention that, but it's very complex and very expensive to offer testing and vaccination at 200 shelters a month. So we unfortunately are not able to do it more frequently than every 4 weeks, unless there's an outbreak.
We are at time, and I really sincerely want to thank everybody here. Dr. Foster, your expert moderating, and all of the panelists for your time and your expertise and your wisdom. I think this has been a really informative and enlightening and hopefully useful conversation. We'll be following up with anybody who registered, hopefully to share slides and resources that were shared during today's discussion. Please do make sure to fill out our evaluation. Harmony just dropped that in the chat box. That'll help us you know if these sessions are useful and how to continue planning them. And really, we appreciate everybody's partnership so much in helping us make this information available to everybody. Thank you again, everybody. Have a great day.
Thank you.
Well.
Thank you. Bye.
Thank you.
Hi, everybody. Thank you.